we are at session 6. We are looking at the metabolic disorders of the newborn, part 1. So we are faced with a lot of metabolic disorders because of the nature of the newborn and the immaturity of organs. So electrolyte imbalances can be very detrimental to the health of the newborn. And this session deals with electrolyte imbalance of magnesium, of sodium. So we're looking at hypomagnesemia and hypermagnesemia and hyponatremia and hypernatremia respectively. So goals for the session. At the end of the session, the students should be able to explain hypo and hypermagnesemia and hypo and hypernatremia. What is it? And describe the acid-base balance and explain the electrolytes and imbalances and identify causes of hypomagnesemia and hypermagnesemia, and also discuss the clinical manifestations and management of hypo and hypermagnesemia. Session outline. The key topics that will be covered are what I've mentioned, but for emphasis, we'll look at acid-base balance, acid-base imbalance, hypo and hypermagnesemia, and hypo and hyponatremia. So once again, we have some textbooks that address this. You could also come across some of these on some scholarly papers that discusses this. So the first we'll look at is acid-base balance. We refer to homeostasis, that is the body's ability to achieve balance of hydrogen ion concentration in the extracellular fluid. And this is acid-base balance. And substances that donate hydrogen ions are acidic, and substances that accept hydrogen ions are alkaline or base in nature. So when we're talking about hydrogen ion concentration in fluid, we are discussing the pH of the substance. So the hydrogen ion concentration of body fluids denotes the pH. And the normal range for extracellular fluid pH ranges between 7.35 to 7.45. So taking 7 as a neutral level, when we go down to the left, that is when we decrease the pH, then acidity increase. And then when we go to the right, and then from 7 and it increases, then pH increases, then alkalinity also increases. So respiratory regulation of carbon dioxide in extracellular fluid. So high levels of carbon dioxide in extracellular fluid increases the rate and the depth of respiration, and more carbon dioxide is exhaled. What I'm saying is that when carbon dioxide accumulates in the blood, then it also promotes respiration by expiring carbon dioxide in the air. And so another thing we have to know is that when we talk about bicarbonate is also a respiratory, it's more related to the respiration. Bicarbonate is more related to respiration. And then decrease in carbon dioxide level depresses the respiration and maintain carbon dioxide. The kidney also controls the pH of the extracellular fluid by removing hydrogen and bicarbonate from the body. And when the kidneys excrete more bicarbonate, the urine becomes more alkaline. And when the kidneys excrete more hydrogen ion, the urine becomes acidic, more acidic. However, in normal situations, the urine is acidic in nature. So when we look at factors affecting fluid and electrolyte balance, one of them is age. you see that in the newborn or among infants, we have higher concentrations. However, as the child grows, you see that it even becomes adult, the fluid level decreases. So the embryo has 95% water in the body, whereas the adult has 60% water. So age is also one determining factor. And the elderly, the water diminishes to tissue loss because of tissue loss. And then factors affecting another is lifestyle. So stress, exercise, the environment in which one lives, and the diet. All these are some factors that regulate the fluid and electrode balance in the body. So now let's look at acid and base imbalance. We know that the body tries to maintain a balance, that is homeostasis. However, when it is out of balance, then illness occurs. So it's very, very important that we do all we can by way of our lifestyle to promote homeostasis in our body, and that is health. So electrolyte disturbance. Sodium is a primary determinant of extracellular fluid. That is to say, it is a major ion, and it also has a profound concentration that produces effects on the central nervous system and the circulation of blood. Hyponatremia is a deficit of sodium in extracellular fluid. When the ratio is too high, there is a hypoosmolar state, and water moves from the vascular space into the interstitial space, just like we have in osmosis. Where there are high concentrations, we have fluid moving from the low concentration to high concentration. That's why we are saying that when there is high sodium level, there is hypoosmolar state because the water moves from the vascular space into the interstitial space, and this causes edema. Electrolyte disturbance. We're also saying that hypernatremia is when we have excess sodium in extracellular fluid. Here we are saying that the sodium in the results in hyperosmolar state, where extracellular fluid osmotic pressure pulls fluid out of the cells into the extracellular. So either way, there is some degree of edema, depending on where the fluid is moving, whether into circulation or into the tissues. So we have magnesium also as one of the electrolytes we are looking at. And we're saying that this is the coenzyme in the metabolism of carbohydrates and proteins, and the mediator and also a neurotransmitter in the central nervous system. So once again, hypomagnesemia is a decrease in extracellular level of magnesium, and usually occurs with hypokalemia and hypocalcemia. So the three occur together. So one affects the other. When there is depletion in one, there is a depletion in the other. So there is some correlation. And then hypermagnesemia refers to increase in extracellular of magnesium. Another we want to look at is phosphates. It also maintains extracellular anion and appears as phosphorus in the serum, and similar to calcium in the vitamin D, and is needed for the reabsorption in the renal tubules. So it's very, very important. And then hypophosphatemia is a decreased extracellular level of phosphorus. And hyperphosphatemia is also increased extracellular level of phosphorus. So another we'll look at in terms of looking at some terminologies when it comes to electrolyte disturbance is chloride. So chloride and water move in the same direction as sodium ions. So the two bind to form sodium chloride. And so when there is low levels of sodium, there is low levels of chloride, and vice versa. A loss of chloride can be compensated by increase in bicarbonate. So there is an inverse relation in this context. So hypochloremia is a decrease in the extracellular level of chloride, and gastrointestinal tract loses a lot of acid content of gastric juices by placing the client in the risk of metabolic acidosis. And then we have hyperchloremia. Chloremia usually occurs in dehydration and also predispose the child or the patient to metabolic acidosis. So hypo and hypernatremia. By definition, we are saying that when there is a depletion in sodium from the body below 135 millimole per liter, then it is diagnostic of hyponatremia. So what are some causes? It's commonly found in infants who are receiving intravenous fluid. So when we give above what is expected, it can have hyponatremia. And also, when we have fluid loss through large surface burns, diarrhea and vomiting, and some kidney diseases, all these will account or cause hyponatremia. And what are the symptoms that we see when the child has hyponatremia? There is dehydration, there is weakness, there is dizziness, there is nausea, abdominal cramps, and decreased blood pressure. So it's important that we check the vital signs and also rehydrate, not more than 10 to 12 millimole of sodium per day, and also monitor the intake and the outputs and pass NG tube, and also group all our nursing activities, because we said there is weakness, so that we promote rest and then nurse the baby in the cot, raise the site and prevent falling, and provide oxygen where necessary. Hypernatremia, on the other side, is when the concentration is above 145. So you see that the normal range is between 135 and 145. We said earlier that when the level goes below the lower margin of 135, there is hyponatremia. So in the same vein, when it goes above 145 millimole per liter, then there is hypernatremia, which is excess sodium in extracellular fluid. The ratio of sodium to water is too high in and result in hyperosmolastate. And the extracellular osmotic pressure pulls fluid out of the cells into the extracellular fluid, and as we said earlier, this results in edema. So when we're looking at the causes, we are looking at water depletion. It's very, very important that we understand that the transdermal loss in preterm infants, which particularly occurs in infants less than 28 weeks of gestation, can be prevented by adequate environmental humidity. Hence, the importance of nursing preterm infants in the incubator where the air is humidified. Also, excessive urine output in preterm infants during recovery, especially from respiratory distress syndrome, which we know that is a common problem we have in preterm infants because of lack of surfactants and premature nature of the lungs. And high risks of fluid loss during vomiting and diarrhea in older children who may also have bowel obstruction, and inadequate lactation may also be considered as a cause. Excessive sodium intake, when we have incorrect fluid preparation, especially when it comes to a fluid like ORS, it's very, very important that when we don't constitute it right, it will have excessive sodium intake. And then also the administration of formula feeds. We need to follow the manufacturer's instruction. When it says give level scoops, we don't give full scoops. you are supposed to use a spatula to level the top of the scoop. If you leave it too full to, let's say, 60 ml of water, then you are not doing the right thing. It's always very important to look at the manufacturer's instruction and prepare your formulas correctly in cases where the mother's condition does not allow it. And then it's also very important to know that excessive administration of sodium bicarbonate will also cause this. Clinical manifestations. We have an intense test or excessive test. We have dry and sticky mucous membrane. We have flushed skin. We have temperature may be increased. There will be decreased urinary output. The skin turgor may be firm, and the newborn may be irritable, and they could also result in convulsion. So when we come to hypo and hypernatremia, it's also important that we know that low levels of magnesium in the blood below 1.7 milligram per deciliter, but in Ghana we use millimole per liter, so 0.75 millimole per liter is diagnostic of hypomagnesemia. The causes are low maternal intake of magnesium, chronic diarrhea, maternal alcoholism, and the other list as we have seen here. And then the signs and symptoms are what you see on the screen. We have weakness, we have cardiac arrhythmias, and some convulsion or nystagmus. All these are symptoms that you may see. So in terms of management, there is a need to replace the fluids and also do magnesium therapy, and also medications to relieve the symptoms are given. So the symptoms are treated. Complications are cardiac arrest or even death, and in some cases, myocardial infarction. So hypomagnesemia is also when the level of magnesium goes above 1.1 millimole per liter. And the causes are excessive intake of magnesium, and then some continuous use of antacid. We know that we have magnesium sulfate preparations of antacids, and in cases where we looked at mother having magnesium sulfate as a result of pregnancy-induced hypertension, and then prolonged eclampsia. So in this case, magnesium sulfate is used, and then medical conditions such as hyperparoidism can also result in this. So what are some of the clinical manifestations we see here? We have respiratory distress, hypotension, bradycardia, and arrhythmias, and asystolic. So management, also we give calcium chloride slowly over 5 or 10 minutes, and also we give IV saline infusion and fusimide to take care of the edema and stop all antacid preparations with magnesium. So the complication is respiratory failure. I think you can also read further to enhance your understanding, because this is all like anatomy, which you might have done long ago. So you need to refer and read further to enhance your understanding.